The radial head can be demonstrated using the 4-position series. It is a lateral projection of the elbow in lateral media. This series is composed of 4 radiographs visualizing the radial head in different positions. To start off, the patient is seated at the end or beside the radiographic table, low enough to place the axilla, the arm, elbow, and forearm in the same plane. The elbow is flexed 90 degrees to place it in lateral position, and for the radial head series, there will be 4 positions of the hand to show the different views of the radial head. For the first exposure, place the hand in supinated position as much as possible while the elbow is in lateral. For the second exposure, place the hand in lateral position with the thumb surface up. The third exposure is performed with the hand pronated. And for the last exposure, place the hand in extreme internal rotation until it rests on the thumb surface. For all of the said positions, the central ray is directed perpendicular to the elbow joint. The first and second exposure will visualize the radial tuberosity facing anteriorly, and the fourth and third exposure will demonstrate the tuberosity facing posteriorly. The fifth radiograph demonstrates the Greenspan and Norman technique. They reported that the radial head can be projected more clearly with reduced superimposition by directing the central ray 45 degrees medially, which is towards the shoulder, using the 4-position series. This technique is useful in elbow trauma. The next is for the distal humerus PAH shell projection. Here, the patient is seated sideways at the end of the radiographic table, high enough to place the forearm rested on the table. Adjust the forearm so that its long axis is parallel with the table and flex the patient's elbow to place the arm or the humerus in a nearly vertical position to form an angle of approximately 75 degrees from the forearm. Supinate the hand to prevent rotation of the humerus and ulna. The central ray for this projection is perpendicular to the ulnar sulcus, entering at a point just medial to the olecranon process. This projection is used in radiohumeral bursitis, which is an inflammation of a bursa that sits between the tendon and the bone, to detect otherwise obscured calcifications located in the ulnar sulcus. Olecranon process can also be visualized with the PAH shell projection. The patient is seated sideways at the end of the radiographic table, high enough to place the forearm resting flat on the image receptor. Adjust the arm at an angle of 45 to 50 degrees from the vertical position and have the hand supinated. To demonstrate the dorsum of the olecranon process, direct the central ray perpendicular to the olecranon process. And for the demonstration of the curved extremity and articular margin of the olecranon process, direct the central ray 20 degrees towards the wrist. As for the AP projection of the humerus, it could be performed in an upright or recumbent position. Arm abnormalities, whether traumatic or pathologic in origin, are extremely painful. For this reason, an upright position should be used whenever possible. For upright, have the patient stand or seated upright facing the X-ray tube. Adjust the upper margin of the image receptor at about 1.5 inch above the humeral head. Abduct the arm slightly and supinate the hand to place the coronal plane of the epicondyles in parallel with the IR plane. Instruct the patient to suspend their respiration during exposure. If the patient can tolerate or was unable to stand, we can position them in recumbent or lying down. Use a sandbag to elevate the opposite shoulder side to place the affected arm in contact with the image receptor or to elevate the affected arm and IR. Supinate the hand unless contraindicated and instruct the patient to suspend respiration. On both positions for humerus AP projection, the central ray is directed perpendicular to the mid-portion of the humerus and center of the IR. This projection will show the entire length of the humerus in AP projection. The accuracy of the position will be shown by the epicondyles. For the lateral projection of the humerus, it could also be performed in an upright or recumbent position. For upright, place the patient in a standing or seated upright position. It does not matter if the body is in oblique or facing toward or away from the IR, as long as a true lateral projection of the humerus is obtained. Unless contraindicated, internally rotate the arm and flex the elbow at approximately 90 degrees and place the patient's anterior surface of the hand on their hip. This hand position will place the epicondyles perpendicular with the image receptor. Instruct the patient to suspend respiration upon exposure. Another position is recumbent, where the patient lies in a supine position with the humerus centered to the image receptor. Unless contraindicated, abduct the arm to place it in center, and rotate the forearm medially until the posterior surface of the hand is placed against the hip. This position places the epicondyles perpendicular to the IR without flexing the elbow. Instruct the patient to suspend respiration upon exposure. For both positions, direct the central ray perpendicular to the midpoint of the humerus and center of the IR. This projection will demonstrate the entire length of the humerus in lateral projection. A true lateral image is confirmed by superimposed epicondyles. When a known or suspected fracture exists, the patient can be positioned in a recumbent or lateral recumbent. The IR is placed in between the body and the affected arm of the patient and close to the axilla. Unless contraindicated, flex the elbow and turn the thumb surface of the hand up. For a recumbent position, the central ray is directed horizontally and perpendicular to the mid-portion of the humerus. For the lateral recumbent, direct the central ray at the center of the IR. This position only demonstrates the distal humerus. The other technique for the lateral projection of the arm is mediolateral. Place the patient's forearm on the anterior side of their body with the hand in supine position. Have the patient face the image receptor, placing the arm in close contact with the IR. Slightly abduct the arm away from the patient's body, and the central ray is directed perpendicular to the mid-portion of the humerus.